attendees will follow. Let me just slowly start with the introduction of this evening. And first, the introduction of myself. My name is Bart Fauser. I'm a professor at the University of Utrecht in the Netherlands, and I am the editor-in-chief of RBMO for now about 5 or 6 years. And this session, I'm co-chairing with one of the editors of RBMO, Professor Richard Anderson. You will see and meet him virtually later. Just some general comments. This is the 4th meeting of RBMO jointly with the International IVF Initiative, I3, spread out over this year, 2021. The first one I co-chaired with Jacques Cohen. That was a very broad scope covering different aspects of RBMO journal. The second one, we focused on embryology, specifically with one of the embryology editors, Laura Rienzi from Italy. The third one, just about 6 weeks ago, the focus has been the new RTS section, Reproductive Technology and Society. We're co-chaired with Professor Nick Macklin from London, and this one will be dedicated to andrology. We know an area which not always gets the attention it deserves, but based on indeed the number of registered participants this evening, apparently continues to attract a lot of attention. So I would like to welcome you on behalf of RBMO, on behalf of the entire team, the RBMO team, but certainly also on behalf of the presenters and discussants this evening. The format is slightly different from what it has been before, with one speech session, so one brief publication, recent publication, which will be addressed, then one showcase presentation, which is a 20-minute broad scope overview from a very senior presenter. You will hear about that later. And then there is a section driven by 2 of the section editors of RBMO, focusing on andrology, and they will discuss 4 papers which have been accepted and published recently in our journal. So that's sort of a general overview of where we are today. And I would now like to give the floor to Professor Richard Anderson. Just for your information, he's a professor of reproductive medicine at the University of Edinburgh in Scotland. Richard, please, the floor is yours.
Thanks very much, Bart. And I'd like to just acknowledge your role in developing RBMO as such an interesting and progressive journal. And you highlighted that we have new sections, and we always like to challenge dogma and push the boat out a little bit. And I think this series that we've been having this year really adds to that. So I'm very excited to be hosting this session, this edition of the webinar with you today. It's a great way to communicate our work with our readers and give space and a platform for our authors and colleagues to discuss these papers today. So it's very exciting to be doing this. As you've said, we're focusing on the andrology section of RBMO today. And our first speaker is Professor Elias Dahdouh. He's the medical director and founder of the ART Center at CHU Saint-Justine in Montreal in Canada. He's been a widely active figure in the field. He authored the 2015 Canadian Obstetrics and Gynecology Guidelines on pre-implantation genetic diagnosis and screening. And earlier this year, he published a systematic review in RBMO on the investigation of recurrent implantation loss. And this is the paper that he's going to present to us today. So many thanks for joining us in this session, Professor, and over to you.
Yeah, thank you very much. So it's really an honor and a pleasure to be here. Professor Fauser, Professor Anderson, and thanks for all the editors of RBMO for this great opportunity. So my presentation is about our review and opinion article on genetic testing of product of conception in recurrent pregnancy loss evaluation. I want to first acknowledge the great work was done by my co-author and friend Billy Cottey on the subject. So some facts and background in RPL. As you may know, 40 to 60% of RPL are still unexplained. This is following ASRM or ESHRI evaluation, full evaluation. So as you may know, there is a high rate of fetal aneuploidy chromosomal abnormality in any miscarriage. Either it's sporadic or even recurrent, and this is around 50% of cases. And this is a natural selection by the loss. So it's either monosomy or trisomy, and there is a natural selection, and you will have the miscarriage. Yet, majority of patients will have a chance of a live birth, at least 40 to 70%, and this is only with expectant management, and depending for sure on age, the maternal age, and number of previous losses. Genetic analysis of product of conception has been introduced to explain the loss. It's either aneuploid, you will explain the loss, this is a random event, or you can even have a euploid finding. This could be a treatment failure. You can adjust your treatment. Suppose you have hypothyroidism, you can increase your synthroid, or you do just another resection for the septum, or it remains unexplained if you have a euploid loss detected by the genetic analysis of the product of conception. So testing of POC can be done through different platforms. G-bending karyotype, this is dated technology. The new technology is chromosomal microarray, either with CGH or SNP, or even recently the next generation sequencing. So if you add your full RPL evaluation combined with analysis of product of conception, you might even explain the reason for the loss in more than 90% of cases. And this is an excellent finding done by Professor Cotte in his publication in 2017 with Popisco in Human Reproduction. Excellent paper. This is the only prospective trial on the subject. And this strategy might define some subgroups for further treatment, either expected management, PGT-SR, PGTA, or even investigation. And I will, in the next slide, I'll explain how we define some algorithm to do a treatment on the subject. So first evaluation, you may go with a full evaluation for RPL patient, either with ASRM or ESHRI workup. So following this is following at least two clinical miscarriage. If the results are abnormal, you will treat according to the finding. If you have any parental unbalanced translocation, you can either refer patient to genetic counseling, and you can consider PGT-SR versus expected management. And if all the results are abnormal, then you may offer genetic analysis for the future loss to explain the loss and suggest for sure expected management. For the subsequent miscarriage, following any normal evaluation, complete evaluation, if we have an aneuploid result, in this case, you can suggest either an expectant management or even offer PGTA for sure after a complete and appropriate genetic counseling, taking into consideration the ovarian reserve of the patient and the woman's age. If any euploid results, this is only in 10% of cases when you have a full normal workup, then you might consider couple for investigational therapy. In this case, you can even consider IV immunoglobulins, aspirin, prometrium, heparin, but this is under research protocol only. So who are the candidates for PGTA in RPL patient? And this is our proposed criteria in this paper. For sure, you should have a complete negative ASRM or ESHRI recurrent pregnancy workup. At least you should detect one aneuploidy seen on product of conception. Usually you will have different types of aneuploidy with different miscarriages. Patient should have a normal ovarian reserve producing a high number of oocyte and blastocysts. I will say at least 2 or more blastocysts enabling to have a embryo selection. For sure, you should do it in a validated and tested genetic platform in a center who has already broad experience with PGTA and blastocyst biopsy. And in counseling the patient, it's very important. You should explain what's the likelihood of achieving a live birth with expectant management. And for sure, PGTA will have an additional cost, and you can damage the embryo by embryo biopsy. And the high risk is not to have any no euploid embryo, no normal embryo, And the worst scenario is to have a mosaic embryo of unknown significance. You don't know what to do with this embryo. And for sure, for the time being, we have a lack of support from society guidelines, including American or European on the subject. So I will say to finish that the evidence is growing for PGTA for recurrent pregnancy loss, but the issue is not yet resolved. Thank you very much, and I will be happy to take your question.
Thank you very much, Dr. Dahdouh. Before we enter discussion about this paper, I would like to ask the audience for this presentation, but also for the subsequent ones, if they have questions they would like us to address, then please not go through the regular Q&A system in the Zoom, but ask your questions separately in the system dedicated for that. Okay, so I see a question coming up. Yeah, there's also, it's about mosaicism to start with. You mentioned that if you do genetic analysis, overall under these circumstances, which is the proportion of embryos that show mosaicism, number one, and number two, and I understand it varies, so it's not going to be easy to give an easy answer, but how to deal with those?
Yeah, thank you for this challenging question. Mosaicism is around 5 to 10% according to published data. For sure, it depends on maternal age, it depends on your platform, and it depends on the center doing the biopsy and the PGTA analysis. And whenever you have a mosaic result, the last recommendation by the PGTA International Society is to see the percentage of aneuploid cells within the biopsy sample. If it's low, between 20 to 50%, these mosaic embryo will have priority for transfer. For sure, you will take the priority for those who will have lower chance of having a fetal chromosomal and congenital malformation. I will explain. If you have a mosaic for trisomy 18, trisomy 21, and Turner, these are the last to transfer. For sure, the priority is to transfer the euploid first.
Okay. Thank you. One more question related to the embryo genetic abnormalities under this clinical condition as a starting point. Overall, and I know there's many assessments, but what is your personal view based on the literature and your own review? What is the chance that you find genetic abnormalities of embryos in this very, very heterogeneous condition as a recurrent miscarriage?
If you are talking about product of conception, around 50%. So even this was an excellent paper, even RBM online on a meta-analysis earlier in this year, showing from Netherlands, showing that even if you have sporadic or recurrent miscarriage, this could be around 50%, and it's independent of the genetic platform used. Even you can have NGS, CGH, and SNP, okay. And even the old G-bending karyotype, you will have around 50% of aneuploidy. Okay. Within the samples of miscarriages.
Thank you very much, Dr. Dahdouh, again. And we have to leave it at this and move to the next session. Thank you so much. Then the next presentation is going to be a highlight with much more time allocated to this, a big, large scale review. The first point is there was a recent paper on sperm DNA fragmentation, but then using this as a biomarker, again, in early pregnancy loss. Professor Sheena Lewis will speak about this topic, the senior author of this publication, but with a much broader scope. So she will also touch upon early pregnancy loss, but different areas clinically relevant where DNA fragmentation can be used as a biomarker. And Professor Sheena Lewis her research career, which has been quite extensive, has really always focused on male infertility, particular sperm DNA damage testing, and how this can identify causes and treatments for male infertility by developing novel biomarkers. Amongst her many prestigious previous appointments, she's been the chair of the British Andrology Society, vice chair of the Irish Fertility Society, and she is focusing also on ethical debate, particular in issues relating to ART. Professor Lewis, the floor is yours. Thank you for participating this evening. This evening for me, this morning for others.
Yes, thank you very much. It is an absolute pleasure to be here. It's the evening for me too. And there's nothing that I like better than discussing sperm DNA. So it's an absolute pleasure to be here. And thank you very much to the organizers for the invitation. Men and miscarriage are something that have been on our minds for quite some time, because although the majority of people think about women and miscarriage, over the last decade, there has been quite a lot of evidence to suggest that there's a relationship between men's sperm and miscarriage. And of course, men as people, although in the fertility sector, we don't often think of men as people, we just think of men as sperm donors. But now we're beginning to think of men as people, and they suffer great loss, as do women. I have a conflict of interest. It's rather a nice conflict of interest in that our university has set up a company to provide male fertility testing, and I am currently the CEO of that company. I know for a long time now we've been talking about sperm counts and sperm quantity, and I'm sure there are many of these types of headlines and papers that make men, their hearts are filled with fear. Sperm count drop could make humans extinct. The male infertility crisis, my failure at fatherhood, ate away at my very being. Falling sperm counts threatening human survival. But I don't want to talk this evening about sperm counts, because the majority of men have lots of sperm. It's the sperm quality which is the problem. I mean, if you think that a man can produce 500 million sperm in an ejaculate, even if the sperm counts are dropping by 50%, there's still quite a lot of sperm. But what is the quality of the sperm like? And in an Italian study by Professor Garrido, they looked at 145 men who had recurrent pregnancy loss. Now, all of these men had excellent semen parameters, so there was nothing wrong with their sperm if they were just given a semen analysis. But when they looked deeper and they drilled down into the molecular quality of the sperm, they found that these men all had higher DNA damage than the men who had successful pregnancies and live births. Then in 2012, I was the co-author of a systematic review and meta-analysis where we looked at all the papers that had been published to date, looking at DNA damage and miscarriage. And this was something quite novel at the time. It doesn't seem so now, nearly a decade ago, but no one had thought of doing it, and the papers had been lost and hidden and neglected. But what we showed was that if the men were divided into two groups, those who had low miscarriage by the 4 different tests and the thresholds which were designed by the authors of each of those tests, if they had low miscarriage compared to low DNA damage compared to high DNA damage, then there was twice the chance of having a miscarriage. So this was something pretty significant. And we felt, having written this, that the community had a responsibility to inform patients of these scientific advances so that they could make informed decisions. Now, since then, quite a number of papers by very prestigious groups have been written, and there is more and more evidence accumulating to suggest that there is a male contribution to recurrent pregnancy loss. A colleague of mine, Jackson Kirkman-Brown, and another colleague, Christy Young, wrote a review paper saying, sperm DNA fragmentation in miscarriage, is it a promising diagnostic or is it a test too far? And I believe they said it was a promising diagnostic, but of the 4 different tests which are around, the COMET, the tunnel, the SCASA, and the HALO, some of the tests are better than others at acting as biomarkers for miscarriage. I had the privilege of being on the guideline committee for the ESHRE recurrent pregnancy loss guideline in 2017. And here for the first time, we brought men into the picture. For the very first time, we had a recommendation that the male partner should assess his lifestyle factors, and that it wasn't semen analysis. There was nothing to do with semen per se, counts, motility, or morphology, but the relationship was with DNA fragmentation. And it was decided that assessing sperm DNA fragmentation in those couples could be considered for explanatory purposes based on indirect evidence. Now, we're currently writing an update on this. It'll be out early next year. And since this guideline in 2017, there have been 14 more original studies, 1 RCT and 7 systematic reviews, possibly more systematic reviews than there should be, but nonetheless, all have concluded that there is a relationship between sperm DNA fragmentation and recurrent pregnancy loss. So, to get to the paper that you've asked me to speak about this evening, the reason why we chose the COMET test to do this was because there are a number of things about the COMET that are different from the other DNA tests that I've mentioned. The first one is that the COMET test can provide more information than other assays. And the reason for that is because we measure the DNA damage in 100 individual sperm, just as you do with a morphology slide. And because we've got 100 different results, we can then plot them out on a histogram, as you see here. And this histogram on the left is actually a histogram looking at the sperm from fertile donors, because we have a fertile donor bank and we got our clinical thresholds from a comparison of the fertile donors, men who have achieved a pregnancy recently, and the patient samples that we're looking at. Now, if you look at this, the average COMET score is the score right across the 100 sperm that we counted. And in the case of these fertile men, it's only 16% damage. Now, the COMET is more sensitive in some ways than some of the other tests. You might think 16% is high, but 25% is our threshold. So the average COMET score is 16%. And then if you look at all the sperm that we would say fall within the fertile range, and this is the low COMET score, the sperm with low DNA damage, 90% fall within this category in fertile men. Now that just shows us that fertile men set a very high store by the quality of their sperm. And of course, this is not surprising if you think from an evolutionary point of view. If you talk about motility, you'd think, well, 30 to 40, 45% progressive motility. Wow, that's a terrific sample. But in terms of the DNA, it has to be 90% of the sample with low DNA damage. And this is why we think it is such a very useful parameter to add to the semen analysis. The other thing is it's reproducible from one sample to the next. And if you fall below these thresholds, then you find that there's an increased chance of infertility, lower success rates by ART, and an increased chance of pregnancy loss. So in a previous study that we did, we found, to our surprise really, that the whole histogram was skewed to the right in men who had a pregnancy loss or whose partners had had a pregnancy loss. And this was really quite marked, as you can see from the 2 histograms here. But in the study design that I'm talking about tonight, we compared 76 fertile donors with 218 men whose partners had 1 or more pregnancy loss. Now, you may ask me, what was the cause of the pregnancy loss? And I can't tell you the answer to that, and no one could, because as we all know, the vast majority of pregnancies happen when the woman's on the bus, or she's in bed, or she's at the loo, or something like that. And getting the products of conception for pregnancy loss in order to see what the cause was is very, very difficult. Anyway, we divided these 218 couples into 4 groups. Those who'd had a first pregnancy loss after spontaneous conception, 2 or more pregnancy losses after spontaneous conception, first pregnancy loss after an ART conception, and 2 or more pregnancy losses after an ART conception. So this was covering everyone we could think of. And again, we saw what we had seen before, that there's a huge skew, and that the men whose partners had pregnancy loss of any kind after any type of conception had much higher levels of DNA damage than fertile men. When we then looked at the actual numbers and compared the fertile men with the partners with pregnancy loss with our 3 different scores, the average COMET, which is all across the entire sample, the low COMET score, which is the sperm with really good sperm, and the high COMET score, which is the sperm with really bad sperm, you can see here, you can see that there's a doubling even more, 124%, a doubling of the amount of damage across the sample. And in terms of the quality of the numbers of which have low COMET scores, you can see that it's halved. So if you were thinking about IVF and you had only 47% of your sperm with good quality DNA, that would mean there'd only be a 1 in 2 chance of, in ICSI as well, a 1 in 2 chance of a good sperm fertilizing the egg. But where we saw the really enormous changes were in the sperm that were badly damaged. And you can see here that there's just a hugely increased proportion of sperm with high DNA damage in these men's semen. So then we looked at sporadic pregnancy loss, and we separated these men out, and we had those after natural conception and ART conception. And you can see that the same trends were seen over and over again, more than a doubling of the amount of DNA damage across the sample for both natural conception and ART. Now that's quite interesting in that it would suggest that certainly there's no increased evidence that ART is leading to these problems. You get the same sorts of effects with natural conception. Again, you get a halving of the number of sperm with good quality in both groups, and this enormous increase in the proportion of sperm with bad DNA. And the same was seen with recurrent pregnancy loss. And again, this was of interest to us because now perhaps you'll say that the results are so evident with 1 pregnancy loss that you couldn't imagine them being any worse with recurrent pregnancy loss. But this is certainly the case. The same indications were here with each of these groups. And it didn't suggest that those men with recurrent pregnancy loss had sperm that were any worse than those who'd only had 1 pregnancy loss. So it's easy to see that all 3 of these COMET scores are highly predictive for pregnancy loss. And when my team did the stats on this initially and showed me the ROC curves, I sent them away and said, that's ridiculous. You must have made mistakes. But it does seem to be the case that the sensitivity and specificity are quite high in this study. Now, something else very interesting has happened as a result of the papers that have been published over the last 10 years. Something which I must say I personally am delighted to see. And this is that international guidelines have started to include DNA damage testing as a useful test. If we look at the European Association of Urology in 2020, of course, they said do a semen analysis first, but then they also said, however, it has become clear from studies that more complex testing than semen analysis may be required, particularly to men belonging to couples with recurrent pregnancy loss from natural or assisted reproductive technologies, which is really what I'm saying, and also with men with unexplained male infertility. And if you think that 25 to 30% of men or of couples have unexplained infertility, semen analysis is fine, but there's some underlying factor. This is, I think, a very, very wise guideline. On the right, we have the American Society for Reproductive Medicine and the American Urology Association. They have published joint guidelines. And as you may know, the ASRM has been quite hesitant in recommending DNA testing. But again, here they are saying 2 things. The first one, I think, is also extremely important, that the male partner should be evaluated by a male reproductive expert. Now, in the UK, urologists are not routinely or regularly part of the fertility clinic staff. but this is saying that really these men ought to be treated as men on their own, as patients on their own, not just as adjuncts to their female partners, and that they ought to be evaluated, clinical histories, clinical examinations, and then consideration should be made of evaluating their sperm DNA as well. And if that wasn't exciting enough for someone like me who's been shouting from a very lonely platform in the past, can I just say that when the WHO laboratory manual was published a few months ago, finally, sperm DNA fragmentation has been included as an extended examination. Now, in the previous manual, a decade ago, it was in the research tools as a promising tool for the future, but now it has been stated that clinically there's growing awareness that chromosomal anomalies and gene mutations underlie a diverse spectrum of male infertility that may underlie many of the anomalies seen in the semen analysis. So here is an admission that the semen analysis is not telling us everything we need to know to both improve outcomes within the fertility clinic, prevent miscarriages in happening, and also possibly improve the health of children in future generations. I'm glad to see that a lot of books are now being written about men and miscarriage and their feelings and how they feel about miscarriage as well, because we have neglected and emasculated men for long enough. So what? Okay, so now we've got some evidence. What are we going to do about it? Is there anything useful that can come out of what I've said to date? I think the first thing that we have to think about is that we're now categorizing couples with miscarriage, even if it's after a natural conception, as broadly infertile. And of course, if people achieve a pregnancy naturally, they're not inclined to think of themselves as infertile. But I think in the broader definition, infertility is anyone who cannot naturally have a healthy live birth. So this is another category of infertility. So what clinical interventions can we have to help these couples? Well, the first thing I would say is we can give them a diagnosis, and that is enormously beneficial for couples. I know many couples have come to our company and had a DNA test and found that they'd high DNA damage, and the men have been, first of all, absolutely relieved that they found a problem, because now they can do something about it. And secondly, they've been very angry because possibly their partners had 5 miscarriages, and the men have said again and again to healthcare professionals, can I do anything? Is it anything to do with me? And they've been told categorically that it isn't. Now, one of the things that we might think of doing for these couples is giving them clinical examinations, because as we know, 40% of infertile men have varicoceles. Varicoceles lead to increased temperature around the testes. Increased temperature leads to poor semen parameters, including DNA damage. And also, there are quite a number of studies now that show that varicocele correction can lead to improved semen parameters in DNA and fertilization and pregnancy rates in ART. But it could be that it could also allow these couples to achieve a live birth naturally. And then a further step, and I'm almost scared to say this because it's such a quantum leap from what couples would be expecting us to say. But I was involved in a randomized controlled trial called HabSelect, which took us about 7 or 8 years in the UK. It was a very large multi-center study, and it was looking at pixie dishes, which are dishes which are covered with hyaluronase. And this, if the sperm bind to this shows that they are good quality sperm, they're active, they're healthy, and also they have lower DNA damage. So could this be a way that we would actually be able to select sperm with low DNA damage that could be used to help these couples? Now, I have to say this study led to some rather disappointing results, and I must say we we had hoped for better, but this is what happened. It was a very large study. It was over 2,000 couples. What we did find was that with the pixie dishes, there was a significant decrease in miscarriage compared to ordinary ICSI, and this was very significant. But this did not follow through to increased clinical pregnancies or to increased live births. However, knowing this, what can we make of this information? Well, I would like to show you this because this is more data which came out of the HAB-SELECT study. It's been provisionally accepted by Human Reproduction. And if you look at this, you can see the effect of male age on pregnancy and miscarriage. In the first graph here, you've got predicted pregnancy rates and you've got the age of the male. Note, not the female, the age of the male partner. And you can see as the age of the man increases, PICSI and ICSI decrease in terms of pregnancy rates. On the right-hand side, we've got the people who did get pregnant. And here you can see that if they just used ICSI and the man got older, then the chance of miscarriage also increased. But if you used the pixie dish, then what was happening was the miscarriage rates stayed the same, even with increasing male age. Now, I have to turn to my colleagues to find out a little bit more information about the effects of age, because one of the limitations that we had in our randomized control trial was that we were using sperm after it had been prepared for ICSI. And so we didn't see the types of increase damage with male age that we thought we might. But if we look at the work here on the left of Don Evenson, you can see this beautiful data showing that there's an increase in DFI, DNA damage with age. And also, if you look at Denny Sakkas's work in the huge study that he published last year, you can again see that there is an increase in DNA damage with male age. So what we think might be happening in PICSI is that we are selecting sperm with low DNA damage using the hyaluronate PICSI digits. And if you look at the three types of sperm, you've got the good sperm are green, the not so good sperm are amber, the terrible sperm are red in terms of DNA damage. And then as the women get older, their eggs are less and less capable of repairing the damage. And this is why we found that with older women, the DNA damage was not able to be repaired, and you got an increase in miscarriage with female age as well as male age. Because as you can see, if you've got good sperm, an under a 35-year-old can deal with it, and even with middling sperm. Now, we have no idea at the moment how much damage an oocyte can repair. We certainly know from the work of the Spanish group and from the Australian group that young oocytes can certainly repair a certain level of DNA damage, but we don't know how much that is. And we also know as the egg gets older, it can repair less. So that's how we explain the data that I've just shown you from the HAB-SELECT study. Going even more and more into the ART, we might suggest that in order to find good sperm with really low DNA damage, we would actually go for a testicular biopsy. Now, that's very controversial, and we may debate this later in this session. But if you look at this, this review by Sandro Steves, you can see that he found the clinical pregnancy rates were higher, the miscarriage rates were lower, and the live birth rates were higher when he used surgically retrieved sperm in couples who'd had failed ICSI with ejaculated sperm. But as I say, I'm not coming out and saying that that's what we ought to be doing with couples with miscarriage. And another paper has just been published in Fertility which disputes this fact. Whatever we say, whatever we do, we have to start focusing much more on men than we have to date. And I think that that's my take-home message. And I thank you all very much for listening to me. And I'm really looking forward to the rest of this evening's event.
Thank you very much, Sheena. That was obviously a masterful overview, highlighting lots of exciting new data, and interesting to see how this is translating into guidelines and of course into the Bible, the WHO manual of semen analysis. And of course, so much of what you've said will resonate with the some of the papers we're going to talk about later on today as well, which is really exciting. Maybe I can kick off. I'm just encourage the audience to add their questions through the Q&A session, and then Bart, myself, and the moderators later will relay these to the questioners. So maybe I can start off with one of these. So, for example, Sung-Tae Kim from Ohio asks, is there any relationship between sperm DNA fragmentation and conventional semen analyses? Do you find higher rates in men with grossly abnormal semen analysis?
I don't think there's a particularly good association. And to be honest, I wouldn't have pursued DNA fragmentation as I have had it been similar to a conventional semen analysis, because it wouldn't have added to our knowledge. What I find exciting about DNA damage was that it was something else. It was something different. It was something that we found, for example, in 40% of men who had unexplained infertility. So I think it adds to what we know. There's a slight association between oligo men who've got low sperm counts. Not only do they have low counts, but they actually have poor quality. But there's very little else which is very closely related.
Thanks.
Maybe another question then from Dr. Roberts about DNA fragmentation. How can you manage this? Is there anything you can influence this process by, for instance, diet or food supplements? Yes, I think there's some work now. The jury's still out in terms of Cochrane reviews, but there is evidence that good diet, losing weight, stopping smoking, not taking anabolic steroids, taking more exercise, all of those things within a 3 to 6 month period can improve your DNA, because of course men are producing new sperm every 3 months. So if they change their lifestyle considerably, then they have a chance they will improve the sperm in the next 3 months.
So Sheena, you've highlighted that your tests are very much focused on using the COMET assay for this, and as you say, other options are available. Yeah. But you're less enthusiastic about it. Are they telling us different things about the types of DNA damage that might be clinically relevant, or in some cases are less clinically relevant and therefore aren't such useful tests?
Well, I do believe that the COMET is a good and a reproducible test, and of course that's why we've pursued it. We looked at the other tests earlier in my career. Yes, there are differences between what we're finding. I mean, for example, ours is a test which looks at single and double strand breaks and alkaline labile sites, which will convert into strand breaks. So what I would say we're looking at is the whole picture in terms of all the strand breaks that you're going to get in sperm. Now, we at the moment are developing another test, which is, it's the same COMET assay, but it's under neutral pH, and that only denatures the sperm in that you look at double strand breaks. And we're actually working with the Australian group with Fab Horta, whom I mentioned earlier, to see if we can find something new about how much repair the egg can do. Can it repair just single strand breaks? Because obviously they're much closer together. But can it also repair double strand breaks? And double strand breaks might be much more deleterious in terms of embryo development. So we can do that with our test, which some of the other tests can't do.
There's clearly a huge amount to be done in developing these tests, because they're obviously very, the COMET is notoriously laborious, isn't it? I think.
Yes.
I
think. Sorry to interrupt, George. I think that what we're going to find in the fertility sector is it's going to be a bit like pre-implantation diagnosis. These tests will be outsourced. You know, some people are saying, oh, we've got to be able to make them all into one test, and we've got to have a clinical threshold which is right across the world. I don't think that's ever going to happen. I think people will just send them off to labs like mine and labs like Don Evenson's to do the work for them, because that's the obvious thing to do. They're difficult to do, they're difficult to reproduce, and they're not for the average person in a fertility lab. I don't mean that they're average. I mean, it's a person in a fertility lab is busy doing a lot of other things. They're not a specialist in this particular task.
There's several questions about the different techniques to evaluate DNA fragmentation. So which, in your view, is the most recommended test? And how do other tests perform in relation to those? And how should we counsel patients nowadays?
Well, I suppose I'd start by saying any DNA test is better than no DNA test.
Mm-hmm.
The second thing I would say is there are a number of systematic reviews that look at the odds ratios with clinical pregnancies and live births. All of the work that we've done is with live birth because that's the primary outcome that patients want. The tunnel and the comet are well up there in terms of the odds ratios that they have. People use the halo test as well, and I fully understand why, because you can use that within your lab. You don't have to outsource, you don't have to send samples off, you get a result there and then. And I understand that that's why people do that, but it may not give you the accuracy that some of the other tests do.
One other question before I return the floor to Richard. There's one I guess interesting question by Dr. O'Donoghue. Is there an oxidative additive which can affect sperm stability?
Well, a large amount, we think a large amount of the DNA damage which occurs in the epididymis. The epididymis is full of senescent sperm and leukocytes and contaminant cells, and a lot of the damage that you get in the ejaculate is oxidative. Now, that's not true of double-strand breaks. Double-strand breaks occur during spermatogenesis, but if you want to decrease the amount of damage from oxidative stress, then taking antioxidants, if I understand the question correctly, taking antioxidants could be a very good thing to do. It's not going to stop your double-strand breaks, but it could alleviate the single-strand break problems.
Okay, Richard, back to you.
Yeah, thanks. I mean, I think just taking up what you said earlier, actually, Sheena, Bronte Stewart from the US, who is one of our most loyal attendees, apparently, is asking about that and the differences between the tests, and saying that many of us will now be clamoring to run the COMET test. Is there a recommended standard test? Do you think that labs that have a real interest in this should be increasingly setting up their own methodologies to do this? And is there sort of a commercialized version of it effectively?
Well, as I say, I don't think fertility labs that are busy doing lots of other things are the place to be doing molecular tests. You need dark rooms, you need fluorescent microscopes, you need a lot of specialized equipment. So that's a problem. I think it will always be an outsourced test if you want it to be done by the experts who do it day and daily. In terms of commercialization, well, we have a lab in the UK, and we're hoping very soon to have a lab in the US. So those are our plans. And of course, as you know, Don Evenson is already in the US and has been there for a long period of time. So I would not for one moment suggest that you don't send your samples to him.
Great. So, and Claudio Telecan from Porto Alegre asks, so thinking about longitudinal analysis, repeated analysis on the same guys, they're asking, after varicocele correction, how long do you think it takes to see an improvement here? And I guess my supplementary question to add to that, of course, is that why has there been such why does varicocele have such a terrible history in terms of having any clinical evidence over many years that improvements really results in improved pregnancy rates?
Well, I think the answer to the first question is between 3 and 6 months. And certainly we work with quite a number of urologists in London, and they send us patients who've got very bad DNA. Then they do a repair, and then between 3 and 6 months later, the DNA damage could have halved, but we always see a reduction. So it seems to work. Now you're asking me, does that convert into better fertility, which is a very, very different question. I think there are a number of papers that have come out recently that show that there is a relationship between improved sperm parameters after varicocele repair and fertility. But I agree with you, it's been something that people have been talking about and not believed. But then people have never looked for varicoceles in infertile men for a very, very long time either. I mean, I think it's a much bigger problem than we had ever thought of, and it's probably just a heat-related problem.
Yeah, yeah. But
Could I follow up on that, Richard, before I go back to you, Professor Lewis? So about the varicocele, because you know, in the infertility arena, this is a very controversial topic. Yes. with a long history. Could it be that there may be a distinction between, as the endpoint, increased fertility or improved IVF pregnancy rates versus decreased early miscarriage rates? Because all previous studies, they focus on fertility per se, not so much on miscarriage. Is that correct?
Yes, it is correct. It is correct. And again, I don't think there's sufficient data for us to really comment on this. But I think we're now just beginning to tease out the fact that there's a big effect with age on sperm quality, and there's a big relationship between sperm quality and miscarriage. And this is really just a decade old. So I would imagine within the next 5 years, we'll get a lot more information. I hope so, because I think we could really improve our ART outcomes, which you must admit have stayed pretty static over the last 20 years, if we looked much more at men and tried to improve their sperm before they have treatment.
Richard, if there are, of course, ways of doing so, other than you mentioned varicocele, but in the absence of that, yeah, we'll have to hope that these additives, I think, are effective, won't we? Yeah, so there is a question on that, and I think you probably have answered it, but let's just try it again. So do you think it's antioxidants that are the key medication that's likely to be effective here, or are there other approaches to these supplements that might be effective? You know, we've had traditionally always advocated zinc and selenium and the like as key factors here.
Yeah, well, I'm a great believer in a good diet, because honestly, and don't listen to what I say and not what I do, because so many of us live on calorie-rich, nutrient-poor diets, you know, on the run, sandwiches from the hospital shop and whatever. But actually, you can get all the antioxidants and all the zinc and all the selenium and all the cofactors which activate the vitamins from a natural diet. So I am very, very highly a proponent of people spending more time on eating well. I think that's very important. Of course, the other things are stopping smoking. Smoking is very bad for sperm. And this other craze for younger fit men and taking protein shakes when they're at the gym, which make their muscles look super, but actually reduce their sperm count and reduce their sperm quality. So those are the other sorts of lifestyles, as well as antioxidants. And the other thing, of course, is infection. We never really look at infections in men. And you know the latest idea that infertility is contagious, and that the female microbiome and the male microbiome, you know, are connecting. I think this is an area where we'll see a lot more in the next few years, because I think you know, if we were to look at infections in men and give them antibiotics if necessary, and check them out in a way which we don't routinely do, we might find that we could improve sperm quality by that very simple procedure as well.
Great.
I see another question, which is a different topic, a different focus from Dr. Cronus-Brown. Is it better to do standard IVF rather than ICSI in case of high DNA fragmentation?
No, it's better to do ICSI. And the reason I think for this is because of the ability of the egg to repair sperm DNA damage. If you think about IVF, you put thousands of sperm in with the egg overnight, and the egg is firefighting in this zone of all these sperm which are releasing free radicals. So they've got DNA damage, so probably oxidative stress, they're releasing free radicals, and she doesn't get the chance to repair the DNA damage of the sperm that has fertilized her. On the other hand, with ICSI, one sperm popped inside the egg, and the egg, we know, has the capacity to repair some of that DNA damage in that sperm. And therefore, I think that is the reason why ICSI works better than IVF for men with high DNA damage.
And that's an interaction, of course, with female age, isn't it?
Yes.
You might want to factor that into the maybe less important for very young couples, but of course, we don't see so many of those these days.
Yeah, indeed.
Yeah. An interesting question on a more practical note is from Sahib Shahani. Can frequency of ejaculation alter sperm DNA damage? Does storage in the seminal vesicle, is that part of the culprits?
That's a very interesting question. And I would love somebody to do a decent study on this, because I think
it seems amazing there aren't data when people record duration of abstinence in every form any man hands into the sperm lab.
I mean, if I had my way, I would have, before men had IVF or ICSI, I would have them ejaculating 2 or 3 times the previous week. And then for the guys who've got unexplained infertility, we know that they've got plenty of sperm. I would have them with a 1-day abstinence rather than a 2 to 5 day abstinence. But there's not enough evidence for that to be the case. But it's common sense, because we know so much damage occurs in the epididymis. Get the sperm out of it.
Yeah, or the seminal, there may be a low-grade infection perhaps in the seminal vesicle, low-grade prostatitis, and I think these are again topics we're going to touch on in the second or the last part of our session this evening. Yeah,
Denny's making a comment about that. There are studies about this, and they
well, Bart, would that be a time, perhaps a fitting point to thank Sheena very much for a fantastic, stimulating presentation and discussion. And of course, she's going to stay around to contribute for the rest of the evening as well, the rest of the next session. So we'll have further discussion on this topic.
Okay.
Bart, so over to yourself.
Yes, Richard, great. Thank you so much, Professor Lewis. Much appreciated. Your contribution, thought-provoking for sure. Then we move to the third and last session for this evening, and it's something new which we haven't done before. So great 4 publications in the andrology area have been selected by 2 of the section editors focusing on andrology and already involved for a long time in RBMO journal. And they will highlight these 4 publications, why it has been accepted, the bigger picture, why it might be of relevance. And so first, let me introduce these 2 senior section editors. It is Dr. Nico Garrido and Dr. Denny Sakkas. Nico Garrido, he's director of the EV Foundation, Director of Research Administration of EVRMA Global, adjunct professor of the University of Valencia. He's been an associate editor of Fertility Sterility, next to being a section editor in our journal and the coordinator of the ESHRE Special Interest Group in Andrology. And then Denny Sakkas, he is involved for many years in RBMO as a section editor. He's the laboratory director of IVF units in various countries, including Switzerland and the United Kingdom. And he has worked with numerous groups establishing their own IVF units. So we would like to give the floor to these 2 section editors addressing 4 papers. Please, Denny, the floor is yours.
Thank you, Bart, and thank you, Richard, and thank you for RBM online to organising this andrology session. I think what's really nice is the 4 papers we're going to discuss today actually sort of talk about a lot of the questions that actually have been raised in the previous 2 talks. So I think it's great to see there's so many people online and have such an interest in this. And before I go into the first paper, I'd just like to welcome also Nico, who's well known in this area. And Nico, do you have anything particular to say initially?
Well, just thanking you the opportunity to discuss these 4 selected papers. I think we choose these ones because of the kind of topics they are covering. I think the audience might find our brief summary quite interesting, and probably will invite them to read the full paper. They cover topics that probably are a constant question in the day by day, and I think they will enjoy it. We have some reasons, quite a number of reasons, in order to select these 4 papers. So if you want to, we can start with introducing the first one.
So Thank you, Nicolas. So the first paper that we thought was interesting and is by Kelly McCarter from the Cornell group. It's entitled "Comparison of Fresh and Frozen Ejaculated Sperm in Sibling Oocyte Recipient Cycles." It's an interesting paper because it's the experiment you want to do if you're doing animal models, where you can control for the egg factor by having young eggs, having eggs from the same mother, and actually you can actually vary the sperm ejaculate. And in this study, what they've done is they've used frozen and fresh sperm, all ejaculated sperm. They were all normal sperm parameters, but they've controlled for the egg factor, which is the hardest thing to do in these experiments, by using donor oocytes. So young women, they've used sibling oocytes, so they've actually done like a paired analysis, if you want. And it's really interesting because they actually found quite a striking difference between fresh and frozen sperm being used as the insemination methodology. It actually surprised me a lot when you look at this data, and basically in the fresh and frozen groups, you had just biochemical pregnancy rates of 76 versus 67%, but the live birth rate was 69% in the fresh versus 44% in the frozen group, and also the implantation rates were significantly different. It's actually a striking difference, and very surprising. I think everyone here uses frozen sperm as a backup, as a standard technique. To see these results, as a comparison is a bit concerning, I think. The one thing that's interesting, and these questions came up, is what happens during freezing. Why is the sperm so bad? And one of the things they even discuss here is there was a counter thought, or a counter hypothesis, if you want, of actually freezing sperm may actually help sort the good sperm, because only the good sperm would survive. So there's some sort of concerns about this. I'm interested in what people think about fresh and frozen sperm. For me, it's interesting because we have known in the past, there's some data, if we want to relate it to DNA damage, that certain freezing protocols will impede or increase the level of DNA damage in frozen sperm compared to fresh. On the counter side, and Nico, I'd like you to comment on this, we always thought the egg can take care of these problems, and especially donor oocyte eggs. We believe the young oocyte, just like in a marriage, can sort of clean up after the husband, and that we thought that actually you would not see this in donor oocytes. And I know, Nico, you have published a number of papers with your group about looking at donor oocyte and the effect of donor, or the impact of donor oocyte on bad sperm, if you want.
It's a quite challenging paper, because when someone starts reading and see the methodology and the design, then you feel real good, because from the same donor who donated to two different couples, one of them using frozen sperm, the other one using fresh sperm, and then see what happens. The differences are so huge, are very, very big. And most importantly, the frozen semen group included about 70% donor sperm, which is even more surprising, because one expects at least comparable results, or at least not as bad. And this will probably make us to check our own data, because at home we use a lot of frozen sperm on a daily basis, and we haven't seen this such a big difference. So, well, sample size, it's not too huge because it's only with 45 pairs of couples. Yeah. But I think it deserves further investigation on this. It's very provoking.
Yeah, before we go to the next paper, I just have one comment about this, because it does highlight something. I'd like to challenge everyone to think of how they treat their eggs and how they treat their sperm. So I'm sure all of you, when you're freezing your eggs, you keep them all at 37 degrees. You take amazing care of them. We vitrify them now, which a lot of research went into. Sperm, we keep it to the side. Some of us don't even worry about temperature. We're using freezing protocols that were developed in archaic times, let's say, and archaic methods. So I'll pass it on to Nico, but I'd like you to just think about how males are treated and how females are treated in IVF, and I think this is just a little part of the difference in how we treat those two proponents of an IVF cycle. Sorry, Nico.
I'm curious about the survival rates in these specific samples because we know they can vary a lot. You can have the same guy every week, every 2 weeks, if he's a donor, showing very highly variable thawing results. But you know, this will make us work a little bit on this.
Yeah. So, Nico, you know, we've already taken a lot of time with the first paper, so I'd like you to just discuss the next ones.
Okay, so we can now move to the second one. The second one we picked is entitled "Birth Characteristics in Men with Infertility," and I think it's also a provoking paper. The main question they wanted to address is related with the low birth weight, prematurity, and being born small for gestational age. If these factors are associated with a higher risk of male factor infertility in adulthood, which is a kind of, I mean, interesting topic and interesting approach. This has been done from Sweden, from Dr. Livner as the first author. And they performed a retrospective study with almost 900 men, which were diagnosed with an infertility factor, together with their female partners in a period between 2005-2010. And they got the data on birth weight, gestational age, and at birth from these medical registers. So they also checked for the distribution of non-optimal birth characteristics and if they were related with infertility factors. And they also built a control group consisting in 2 men for each index man that were born in Sweden the same year and as the index man. So the methodology seems quite adequate, and the results are very, very interesting because the likelihood of having been born small for gestational age was almost 5-fold higher in men with male factor infertility when compared with unexplained infertility. Also, men with male factor infertility were more often born with non-optimal birth characteristics than the control group, and it's approximately 6% more. And also the reference group, about 3% more. And finally, those men showing azoospermia were more often born with non-optimal birth characteristics compared with men without azoospermia. It's almost twofold, which is kind of a very, very interesting approach because, you know, every time I feel there's more and more interest on the obstetrics and perinatal outcomes in children conceived by IVF. I think this is a growing interest in these years. This is a very novel approach, and I think it opens a nice research line. There's an increase of risk of disease later in life in these children that experience some perinatal and obstetric bad outcomes, let's name it like this. And it's very, very interesting because in the past years, I always felt not too much comfortable when there were some papers comparing this kind of perinatal outcomes, showing, for instance, such a stimulation protocol is providing children with less weight, 100 grams less or 200 grams. And then one thinks, okay, how important is this? And finding that this situation may bring infertility in the future or is somehow related with adult infertility it's also a very, very interesting finding that probably deserves further attention. What do you think about that, Denny?
I completely agree, and it's now, you know, a series of these papers showing a male effect on outcome. And I think, you know, we're talking about one of the papers by Mike Eisenberg's group later on, but their groups really led the field in, I think, as far as I'm aware, on just showing the impact of the male on outcomes. And initially the Kandwala paper that came out looking at paternal age, looking at outcomes of pregnancy, showing that older men, mostly their partners experienced adverse outcomes with their pregnancy. It's all sort of linking up in some way, you know, whether it's DNA damage, whether it's age, whether, you know, it's male infertility in general, the, you know, poor sperm parameters. I think it's really giving us, shining a light, I think, now that there are intricacies in the sperm that we just don't understand. And, you know, it's interesting, we just had Sheena's talk on looking at Comet. Yourselves, I know, Nico, have looked at proteomics of the semen to look for characteristics, and I think we're all trying to find these factors, and they're probably, I don't think it's one, I think it will be multiple factors that we're looking at eventually, but there's, I think it's
related, right?
Yes, I think in some way it's becoming unequivocally apparent that the sperm actually have a much greater role than we always thought. You know, we put a lot on the egg, but there's something hidden in the sperm that, you know, we still don't understand, that actually impacts much later. And, you know, we even know these from some studies which show transgenerational effects. So I think this is a fascinating study, and it's amazing the databases the Northern Europeans have. It makes me jealous that they can go and look at this data. Right, perfect. Should we move to the third? I think so. So the third study is by Gao et al. It's again a really interesting study. It's on age-related changes in human conventional semen parameters and sperm chromatin structure assay defined sperm DNA integrity. And it was interesting, in the space of 1 year, there were 3 quite large papers looking at between 15 and 20,000 men. Don Evanson, and I'm happy actually his came out first, was looking at age related to DNA fragmentation. We had a paper published just after Don's, probably a month after, looking at oxidative stress adducts and DNA fragmentation related to age. And then this paper also, you know, and they form a good series of papers. They all back each other, and they all look at some intricacy of slight difference. And this paper by Gao et al. Was on, I think, over 18,000 semen samples, again looking at age. And it's incredible looking at DNA fragmentation and age, which with whatever message this method, sorry. This is looking at the sperm chromatin structure assay type analysis. And literally you can draw a line. You couldn't make up the data better, that young is lower, the older you get, the higher the rates of DNA fragmentation. And it's a bit concerning in many ways, because in a lot of times we're starting to use these patients, these older men, especially for donor oocyte cycles, and given, you know, we are treating males or couples that are slightly older. So I think we really need to start understanding the male age effect much better. This paper in itself was interesting because it showed that age was negatively correlated with semen volume, total sperm count, motility, the high DNA fragmentation index, and positively with sperm concentration and the DNA fragmentation index. So it sort of, it brought together a lot of the data, and actually it's interesting because we had some questions earlier on about, does age affect sperm quality? Not just in sperm numbers, and that, but it actually obviously seems to affect sperm quality at the DNA level. Sheena spoke earlier about age and using the comet assay. These are different tests, but they all show a change in DNA integrity as men get older, and that coupled with the many studies that are coming out now showing age-related effect, especially on neurodegenerative disorders, which is really very worrying. Some of the autism spectral disorders, and again, even in animal models, it's unequivocal again that you have an age-related effect on from the male on outcomes. So I think this paper really sort of puts it together, and it's a lot of men. It shows a very interesting effect of age versus DNA fragmentation. One of the questions I always struggle with is that we see, the older men having changes in their sperm DNA structure, but are those older men similar to the men we're using ICSI for example? What's the difference in those? And are we sort of using a similar type of sperm when we're treating young men, but with male factor infertility? And what's interesting is the data from the previous paper that showed that male factor infertility does have an effect on outcomes. So I think this is a really interesting paper. As I said, it's part of a large group of papers now looking at many men using similar technologies and showing definitely there's an age-related decline, if you want. We always talk about the female age-related decline, but there's a parallel decline, maybe not as evident that we see in the oocyte, but there's definitely one going on in sperm also. Nico, did you have something to add? Sorry.
This paper brought me a couple of questions. I mean, first, I'm curious. I think the trends are clearly seen, no doubt about this. But my first question is, okay, does this change in the trend induces a change in the treatment? For instance, is this decline in the number of sperm enough in order to have, for instance, a different proportion of ICSI on those older men? I'm not sure, because this could be directly a clinical consequence of this decline. And this is one question I would like to also address. And second, I fully agree. I mean, you see how increasing the age, increased DNA harm, and this fits very well with the next generation health status. And there are papers out there showing that autism, schizophrenia, diabetes, obesity, and achondroplasia are increased in children conceived from aged men. So it's not only about the quantity, it's not only about the quality, but also safety of using sperm, which is, I think, the next level. You expect quantity when you talk about the numbers. You expect quality when, okay, this can raise a child or not, but you expect about the quality and the safety when it's related with future health problems in the children. So it's very interesting.
It's a very complex question, and I know Don Evanson used to talk about his test as the tip of the iceberg, if you want. So the DNA fragmentation may not be evident in all the sperm, but it indicates that there's something going on, that it's a decline, let's say, in the quality. So are we looking at these older men? Are there hidden factors that we see? The thing that intrigues me, are the miscarriage rates and that we see associated to males, and so which means the sperm are good to get there, but there's something that goes amiss in the timing later on, developmentally, that may be paternally driven, and that's where we really need to start looking at better tests. And I think Sheena talked about comet assay. There are many other tests out there people are trying to develop now, and I think these will be really helpful. I'm not going to go into it, but there are sperm selection techniques that now people are looking at, and whether that will help or not will be another question. And I think so. Finally, to bring this sort of around together, the final paper is a really nice review. So, Nico, if you want to just go over that one.
I think it fits perfectly well with all this that we have been discussing. So the last one is authored by Tony Chen from Stanford. And it's a nice review paper called Male Fertility as a Marker for Health. This comes, as Denny said, from Mike Eisenberg's group, which is probably the most active in covering this topic. And I like this paper for many reasons, but I think in order to generally describe the contents, the paper can be divided into two different halves. During the first half, the authors are relating which are the most relevant risk factors for male infertility. So things that might be causing or inducing male infertility. In this sense, they cover topics as genetic things, infections, obesity, psychological stress, oxidative stress, drugs, diet, pollutants. So there are many different risk factors that for me are very, very important because some of them can be avoided. And these evidences should be probably a part of the workup of the infertile couple once they attend an infertility clinic. So identifying which are the risk factors that are related with male infertility can, to some extent, theoretically alleviate this male infertility situation and probably contribute to reproductive success. But this is only the first half of the paper, because on the second half, it contains a more detailed approach and probably closer to the title of the paper, because it's the nice theory and hypothesis that male infertility is also a sign for future disease in men. And this opens another different perspective, because probably in these cases, you should be counseling not only from the reproductive perspective, but also saying that these patients might have in the near future or in the far future an increased risk of hypogonadism, cardiovascular diseases, hypertension, diabetes, cancer, and autoimmune diseases, but even mortality. And also that this infertility situation can impact on psychological aspects and even economic burden in these males. And this is all supported by recent and wonderfully presented information, and could be very, very useful for all the readers in order to directly apply some of this knowledge to the clinical practice. What do you think about this one, Denny?
It really, I think all these papers and the presentations we had, sometimes, and it would be interesting for Bart and Richard to comment on this too, when they see infertility patients, a lot of times the male may not be there. Mm-hmm. And when they see the couple, it's mostly the female that speaks. And I think what we're being sort of told now is that the male actually has a lot to do with this. It's obviously it's 50% of the genome, but for some unknown reason, they've sort of been left aside, and we've concentrated a lot on the female and the egg. But all this data now is pointing to a much broader role in terms of the male and how we should be looking at them, how should we be counseling them, the effort we should put into maybe diagnosing the male. And I think, as I said at the beginning, taking care of the sperm as a gamete also just as important as we do with the egg. I think all of that sort of brings to point, the reason we're having this webinar, I think, and how important andrology really should be, and maybe we've forgotten that a little bit.
Okay, Denny and Nico, because this may be a nice sentence closing this session, but before doing so, I would like to invite Richard. So is there anything you would like to address more focused on general, the bigger picture of andrology in general, but also, of course, the position within RBMO? And do you have specific questions for Denny or Nico?
Yeah, thanks, Bart. Well, I think we've had a fantastic discussion, haven't we? And I think that's the papers that we chose for this session, you know, the enthusiasm with which they've been discussed just highlights the importance. And I think Sheena said the same as well, Sheena Lewis, that, you know, we need to not regard men as just turning up and depositing some sperm in the lab and then going away. You know, we wouldn't dream of missing important diagnoses in our female patients. And I think that the review you've just been so eloquently discussing highlights that we should be looking for diagnoses in our male patients that will affect their long-term health. And, you know, one would not want to be in a position where some patient comes back, you know, in 10 years' time, said, actually, you know, that problem I've got now, that could have been picked up when I was at that infertility clinic 20 years ago. And, you know, why didn't you point that out to me? And I could have made myself healthier for the rest of my life if you'd identified that at the time. So I think that we've actually got an exciting opportunity of broadening our influence, that we're not just fertility doctors, we are physicians looking after our patients at a critical point in their lives. So I'd like to think that was perhaps the most important thing we could take home from this session tonight.
Thank you, Richard. Thank you, Denny and Nico. Sort of slowly going towards the closure of this webinar. Indeed, andrology, it is very clear from all presentations, needs much more attention. And now maybe slowly we have the knowledge and tools to actually make that happen, because this has been mentioned now for decades, but not too much has happened so far. But maybe we are on the edge of something new. And certainly as a journal, as RBMO, we embrace this. You know, it's part of the history of the journal and of Bob Edwards, who has always been focusing on the sperm almost as much as on the other side. So yes, it fits the history of the journal, and we would really encourage you, the participants, the audience for tonight, to submit your andrology work to our journal. Then maybe before I give the floor to Richard again to close this session, a few more words about RBMO. And this year, certainly our collaboration with I3 has been very fruitful, very challenging. You've seen tonight lively discussions, a wonderful format. I would like to thank all the contributors this evening, but also in previous events. Wonderful, and we would love to hear your feedback as well later on about today's session. I think it's fair to say that RBMO is alive and kicking. You've seen some of the representatives today, but also in previous RBMO I3 events. We are now, we've been doing many things, certainly focusing on reducing the time between submission and acceptance. I think we realized that, you know, it's less than half than it was 2 years ago. So we really worked hard on this with the editorial office staff. We've introduced much more focus on good reviews and actively going out assessing relevant topics and finding authors to cover this. We have a new section, as we've highlighted previously, the RTS, the Reproduction, the Technology and Society, different aspects of reproduction which have not been seriously covered before. We have recently embarked, and there's been a lot of interest in a counter-current contribution, which is, you know, that we invite actively opposing views, so people who have views different from mainstream thinking, which I think is intellectually challenging, now, and so on and so forth. So we are really happy with all these initiatives. Please, for you being present this evening, follow us on Twitter, LinkedIn, more webinars to come, our new look and feel of the journal and the website, our alerts, the RBMO digest distributed by Elsevier. So we are really trying hard to reach out to all of you and to make known who we are and what our high ambitions are. So thank you very much for this evening on my behalf. And then I give the floor to Richard to close this session.
Thanks very much, Bart. And I'd just like to echo your thanks to everyone for attending and making this such a stimulating session today. When you leave the webinar, you'll get a new browser. It'll open with a very brief feedback survey of just 4 questions, and we would really appreciate your responses to let us know how much you enjoyed this and what you'd like to see in the future, because these are really designed with our audience in mind. It's your choices. I'd like to thank everyone who's taken part, my co-chair Bart Fauser and our main speaker Sheena Lewis for such a great presentation, and our other main contributors Elias Dahdouh, Denny, Sakkas and Nicolas Garrido. Also, many thanks to all those behind the scenes, the organizing committee of the I3 who've produced these excellent webinars, particularly Jacques Cohen, Peter Nagy, Giles Palmer, Thomas Elliott, Marianne Seyfé-Tez, Scheisse Sanrudden, and Alison Bartolucci. This isn't the end of the day for the year. We've got another one. There's another of those in the new year. But in the meantime, there'll be another I3 session just at our usual time, in 2 weeks' time, Tuesday, the 16th of November. So at that event, Prof. Darren Griffin will moderate a special session on the Y chromosome, and that will have main speakers, the world-renowned evolutionary geneticist, Professor Jenny Graves, and Dr. Sherman Silber, who can always be relied on to generate a lively discussion. And they'll be talking about the Y chromosome in fertility. So thank you all very much for your participation and questions and engagement. And please remember to complete the survey as the session closes. And thank you and goodbye, good morning, good night, depending wherever you are around the world.